Hello, everyone. Thank you for joining us on this Arthrex Bunionectomy Series. I'm Dr. Noman Siddiqui, and in this episode, we'll be discussing our introduction to MIS and how it has impacted our practice, as well as general recommendations for just getting started. I practice in Baltimore, Maryland, and I have the honor of being joined today by Dr. Tom Harris from LA, Dr. Joseph Park from Los Angeles as well, and Dr. Jim McWilliam from White Plains, New York. Gentlemen, thank you for joining us on this awesome topic that we're all passionate about. Now, I've been doing MIS for over 12 years, and I first started doing this when I was in residency and have had a passion for it ever since. Dr. McWilliam, why did you decide to dive into MIS, and how long have you been doing it for?
So around 2004, 2006, a minimally invasive bunionectomy procedure, sort of a second generation, described by Bosch and popularized by Giannini, became kind of popular in the literature, so I embraced it and started doing them with really pretty good results. Around 2008, though, a paper or two came out that suggested that this was the wrong procedure to do and suggested there was a high complication rate. And as I was early in practice, I couldn't really go against the tide of what was then conventional wisdom. So I moved away from MIS surgery, but I retained an interest in it and followed its progression in Europe, so that by around 2012, I was ready to start doing it again. Now, as more instrumentation and more fixation systems have come out, it's become a big, huge part of my practice.
That's very good. No, I remember that in 2007 when it kind of took a step back. So for you to stick with it, it was pretty impressive. Dr. Park, what was it for you? What convinced you that MIS was the right method for at least the bunionectomy side?
I wasn't happy with how my surgical bunions were turning out, whether it was a recurrence or the cosmetic appearance or the recovery process. Patients weren't happy, and I was on the quest to find a better option. So back around 2018, 2019, attended a course that you taught, Dr. Siddiqui, and that kind of started that process for me. I was able to find something that was reproducible and fast recovery, and patients were very happy with it, and I was happy with the recovery process and the range of motion.
Dr. Harris, how would you say MIS has impacted your practice?
Yeah, I started kind of the bunionettes of all things, and then kind of moved my way toward calcaneosteotomies in the mid-2010s. Eventually, late 2010, started getting into the bunions and really took off after that. So it's really made a huge boon for my practice. It's made my life much easier. I think the surgeries have been just having great outcomes, whether it's a bunion or calc slide. Just really has opened up a new way of doing surgery in general.
So to follow up on that, you have a unique practice in a very difficult part of the country. Has it differentiated you any with the other surgeons, or have you found yourself people seeking you out for this unique method?
For sure. Sometimes people are coming to me specifically for an MIS bunion, so to speak. I think it's helped me personally just because it just gives you another tool in the tool bag to use. And as you get more adept with it, you'll be like, how can I do this via an MIS approach? As you get more comfortable with the technology and the tools. So I think in that way, it's differentiated me from some of the other peers.
Dr. McWilliam, I know you use the plantar lapidus plate. What is your algorithm when deciding and choosing MIS bunion surgery versus a lapidus procedure?
Prior to me really embracing MIS, maybe 8 or 10 years ago, 90% of my bunions were done via a lapidus approach. Now that's changed significantly so that probably 95% of my bunions are MIS approach. I think my indications for lapidus are really profound systemic hypermobility, a bunion that's being done in concomitant with a painful flat foot, or someone who has a lot of midfoot arthritis. So those are my indications for lapidus. Everybody else pretty much gets an MIS approach.
I'll pose the same question to you, Dr. Park, and then Dr. Harris. Since for you, Dr. Park, where you've transitioned to more MIS, were you doing lapidus before, or were there other osteotomies that you considered prior to that?
Prior to MIS, I was certainly doing much more lapidus and proximal osteotomies and procedures. It's still about what's best for the patient, but I found that with MIS, I can have a better reduction with less complications and still correct and regain the mechanical axis. So you have all the benefits of a more proximal procedure, but with a fast recovery.
Dr. Harris?
Yeah, I've kind of had a bunion evolution of sorts. I did a lot of opening wedges to start off with, and like those, and then I kind of shifted into Lapidus, and like those, didn't love them, and I was really trying to push the limits of my open chevrons. So kind of similar vein here, but now with the best of both worlds, being able to do that through a minimally invasive approach, it's kind of made those distal procedures much more common and much more reproducible, so to speak. So that's how I've kind of come about. I'll still do an occasional Lapidus here and there if there is some arthritis, if there is that really wide plantar gapping on the lateral view as well. But I'd say MIS now 80 to 90% of the time.
Now, would you say you were also doing with your Lapidus or even your base wedge procedures, were you opening up the first MTP joint at that time as well for either a ostectomy or what have you?
Correct, yeah. So that'd be the first thing I would do that. I'd do a lateral capsular release, even release some of the tissues, just lateral to lateral sesamoid plantarly, and then the medial eminence removal.
Yeah, and I think that's what was for me. I was doing a Lapidus, but I was also doing a distal bone resection because all of us have been trained in those open methods, and that is the common wisdom. You have to resect the bone and do a fusion. And that's what, for same thing, I started noticing that we're doing multiple procedures, yet getting inconsistent outcomes, despite what should be, what you would think is the either hypermobility or a larger bunion. And that leads me to the next question that, folks that go into MIS, and for me, I have done MIS on pretty much every single patient, whether it's a large IM or small IM. Have you found it there's a limit to IM correction? Because that's a common question we get at our courses. Is there a limit to how big an IM can be for MIS correction?
I think theoretically there is. If you have an IMA that's in the mid to high 20s, I just try to conceptualize where that capital fragment is going to be once you shift it over laterally. And if it lines up pretty well with the base of the first metatarsal in your head and how you conceptualize the shift, and you've corrected most of the IMA with a 90, 100, 99% shift, then I think you're still okay. But if you're looking at an arthritic joint at all, then you could run into some problems, and that's a variant of hallux rigidus, or just a huge IMA, which are out there as well. I'd probably avoid it.
Dr. McWilliam, now we've talked about hypermobility. Now, do you think it's a contraindication to do a hypermobile joint with an MIS correction?
I think it used to be, but I think my indications are expanding so that I don't, similar to what Tom was saying, you have to be able to visualize the correction. And I think a greater than 100% shift of the metatarsal head to correct the IMA because of the non-compressive nature of the screws that we're using, and because of the strength of the construct. And we see that even with a huge shift, the bones heal. I'm finding that there's less and less contraindication to doing a distal MIS bunion procedure despite whatever the IMA is, or even in the face of hypermobility, I'm changing.
Dr. Park, you came to the course and now you're an expert in this method. Would you say that the IMA was a limitation for you, or was it never an issue?
Initially, my thought process was that the smaller the metatarsal angle, the easier the reduction. And that was maybe some of the first types of cases I wanted to do for MIS. As I progressed with this procedure, I've noticed kind of the opposite, where the larger the IM angle, it's easier to reduce. You have more space in the inner space to reduce that capital fragment. And it's easy to reduce. The soft tissue coverage is much easier there as well. So it's a little opposite of what I thought initially.
That's a great point. And that goes to show, for me, I've stopped doing a Lapidus almost 7 years ago for that very point, because I realized that in this technique, the large IMA versus the short IMA, we're not realigning the anatomic structures, we're realigning the mechanical structures or the mechanical line by which the joint works. And I think that's where all those other features of opening up the joint, doing an anatomic fusion at the first TMT were, though on X-ray looked great, but functionally didn't have a great outcome, whereas the mechanical realignment, by just taking the head, putting it where it should be, not disrupting the joint at the MTP joint, not fusing the MTP joint, first TMT joint, we were able to get what you guys have noticed and what I'm noticing is earlier return to activity and maintaining, most importantly, that function at the MTP joint. Now, Dr. McWilliam, you again touched on this earlier, so I want to come back to it. Knowing the history of this technique that you alluded to, why do you think this generation of MIS is more successful than the prior?
Well, just think about the evolution of the procedure. So the first generation, quote unquote, was non-fixated. There was no hardware involved. So technically, it's easy enough to do an osteotomy. It's easy enough to manually realign the joint. then it's kind of hard to maintain the alignment. And that's why I think a lot of those techniques weren't adopted very well. Then you add some sort of internal fixation in the way of a K-wire. The outcomes are probably more predictable. You can certainly get bigger corrections. But once you introduce rigid internal fixation with the third generation technique, probably came around about 2010, 2012, then this became a much more reproducible procedure and you could address much bigger deformities. The problem was not with doing the osteotomy, the problem was not with doing the shift, but the problem was putting in the internal fixation because it's technically a little bit tricky. And people who aren't patient or aren't dedicated to doing this and don't really try really hard to train themselves in doing it, found it very difficult to fix these osteotomies. So I'm sure there was a lot of lack of adoption because of the technical difficulty of the internal fixation. But now that we have a lot of instrumentation, so we have a shifting device that makes the deformity correction easier. Now we have a trajectory device that makes it much easier to put in rigid internal fixation. I think we're going to see this really explode because it's going to be much more reproducible without as much of an investment in personal training or time to learn how to do the procedure.
Yeah, in 2019, we had an article that showed in the Generation 2 method, the pin fixation that was used had a 19% soft tissue infection rate. And I think with this method, we've really decreased that. And that can be a problem for a lot of patients and a lot of discomfort. Dr. Park, for someone getting started with MIS, what would you say to them? How should they go about it?
What I'd say to myself from 2018 to 2019 when I was first starting out with MIS bunionectomies is to really spend some time as far as positioning, where I would want to sit, which type of X-ray, mini C-arm versus big C-arm, and whether to sit down or even stand up there. So that's a big part of the setup is going to relieve a lot of your headache and stress.
Dr. Harris, any other pearls you would add to that about patient selection or how to set up the room?
Sure. I don't think you'd want to start your first MIS bunion on a really severe bunion, personally. I think there's a sweet spot in the middle of a moderate bunion, which that's really probably technically the easiest to do. There's some concerns about too small of an IMA versus too big of an INA, but there's a sweet spot there of 15, 16, 17, where I think that's a good spot to start. Your open bunions may take you an hour, hour and 15. The first one of these can take 2 hours at first, so give yourself plenty of time and don't be stressed or have a hard out, so to speak, and put your case in the morning and then have another case following you at 10. I'd put your first case on in the afternoon so that there's no one following you and you can take your time on it. I think those sort of things, because what Dr. Park was saying is important, trying to figure out using the fluoro, using your foot for the control, for the speed, all that stuff is kind of brand new and you really want to get that down. And cadaver courses are huge and help a lot. You should definitely feel comfortable before you start it, but doing your first case is really another jump.
Now, you would say that that time from the beginning, let's just use that example, 2 hours, would you say that is now your current, how long is it taking?
Yeah, now anywhere from 20 to 40 minutes. Yeah.
That's about right. Dr. McWilliams, same for you. You've always mentioned in our courses that perhaps even a bigger bunion would be even easier. Can you elaborate on that?
Yeah, if you think about the trajectory of the screws, if the screws are coming at a not very acute angle relative to the metatarsal, then getting that guide wire through the first metatarsal across the osteotomy site to engage the metatarsal head can be very difficult because of skiving and stuff like that. If you have a larger IM angle, then you're going to come much more, quote, perpendicular to the cortex of the bone, making it easier. So I would kind of not argue with Tom, but I would argue with Tom, I guess, and say that a bigger bunion is going to be easier in terms of fixation, because we talked about the challenges. The osteotomy is easy, right? The shift is easy, and it's even easier now that we have a shifting device. But even with a trajectory guide, it can be a little tricky to get the guide wires across the osteotomy for the cannulated screw fixation. So for me, a bigger IM angle is actually easier than a smaller IM angle.
So Dr. Park, you were mentioning about the setup. Is there certain ways that you like to set up your C-arm? Because there's also a difference between the surgery center and the hospital. Can you elaborate on that?
Absolutely. And this is going to be unique for each surgeon and different for everyone. There's no best way or standard way. But as a right-handed surgeon, I like to face toward the patient for a right foot bunionectomy. And then for the left, I like to face down towards the patient's foot. I use the mini C-arm just because it's easier to maneuver and it's readily available, whether it's at the surgery center or the hospital. And my personal preference is for the mini C-arm to come in from the patient's right side for either side that I'm operating on. So whether it's a right foot or a left foot, it makes it easier for me to maneuver around to work on top of the foot or on the inside of the foot.
Dr. Harris, once you decided that you're going to commit to this technique, how long did it take? How many cases before you feel, okay, I'm doing this correctly? Because there's data that came out pre-instrument guided, like Arthrex has, that was about 50. Then more recently about 30, roughly. I mean, can you elaborate?
I mean, I think it's a great question. It's hard to answer. I think for me, it's probably between 5 and 10. I think, using the guides, the jigs has made things technically easier. So I think that's definitely decreasing the learning curve. And even I've seen it over the courses over the last few years as the jig and the guides were introduced, the participants seemed to pick it up a little faster and be able to put their K-wires in quicker than it would be pre-jig time. So for me, personally, I think it was between 5 and 10 where I really felt comfortable, but I think everyone's going to be a little different. I think 3D spatial, putting that in your mind and where things are is really important doing this because it's really a fluoro-driven sort of procedure.
Yeah, Dr. McWilliam, would you agree with that?
Yeah, I think I was unique in that I was kind of studying this for a long time before I fully embraced the third generation technique. And I did some courses in Europe and I got my hands on things. I did a lot of practice. So I think that's the key. And I think if you're thinking of adopting this, you should take advantage of the industry's willingness to train you. There's tons of courses that are available, and you should take like a local course, a regional course, and a national course. And you can get yourself comfortable and really decrease that learning curve by training on cadavers, like we said.
That study that you mentioned is from, I believe it's 2017, where it says approximately 53 cases to become familiar with MIS procedures. And then the subsequent study in 2019 cut that in half, essentially to 27. And this is pre-jig, pre-parallel guide, pre-improved instrumentation. And I believe that cuts it in half as well. We haven't had studies since that 2019 paper. For me personally, I feel like I'm kind of a case study. I came in without the experience that Dr. McWilliam had or the practice or the exposure and kind of came in cold in 2018, 2019. And for me, I felt comfortable after about 8 to 10 cases. But I think we can cut that in half from 27 down to 12 to 13, I think is a reasonable number.
Yeah, I think if I can just add a couple comments to that is that I've noticed the guys and the gals that are doing more operations per month. I think it's really based off that. If you're in the operating room constantly doing this, you're going to have a smaller learning curve, and it may be just 5 to 10, but it's okay if it's a little higher, I think, because in the end, inevitably, once you get there, it becomes your go-to. And I think that's why this technique is so nice. Experienced surgeons, younger surgeons can all become adept at doing this pretty well. So that about covers it for this episode and our experiences with adopting MIS bunion correction. Be sure to watch our other Arthrex bunionectomy videos to learn more about the technique and the other questions that arise. Thank you very much.